Welcome to The Better Life with Dr. Mary Ann Pinkston. Join Dr. Pinkston today as she teaches you how an integrative approach to health, combining holistic and contemporary medical information, can lead you to the better life. And now, here's your host, Dr. Mary Ann Pinkston.
Hello, everybody. I am Dr. Mary Ann Pinkston, and this is The Better Life with Dr. Pinkston. And we are in studio today. I actually have an in-studio guest, and I'm absolutely so thrilled. So I have Dr. I'm going to do it. See, Dr. Roger Moczygemba.
Perfect.
And this is somebody I've known for quite some time. I don't know if we've ever gotten to spend this kind of quality time together to be able to go over some of the great things that you were doing. But I really wanted to have him on the show because, you know, as people are searching for a new way to, get into healthcare, and either from a doctor's side, or if you're a patient who is, looking for something a lot better, a lot more efficient, something that satisfies. I think these days most people go to the doctor and really aren't satisfied with the changes that have occurred. So you've got a new model, and we're going to discuss that. But first, you have a lot of time, I think, with some of the legislature and some changes, and some of the healthcare legislation, but some changes in the healthcare model and whatnot. So I would love to hear about you first, and then we can get into the direct primary care model.
Okay, so you wanted to hear a little bit about me.
Yeah.
I'm on Chip Roy's Healthcare Advisory Committee, so
Beautiful.
I'm participating in that.
Yeah.
I feel my role in there is to provide a model for the committee and for him as to what affordable access to healthcare can look like.
Yes.
So I work with some wonderful other doctors on that committee. Let's see, some other things that I've been involved in along these lines. I was the founder of the San Antonio chapter of the Free Market Medical Association,
Nice.
and I was in that role for about 5 years. And during that time, we started it from scratch, and it was my goal to promote price transparency, which is the goal of the parent organization, which is nationwide. My goal here was to create a free market healthcare community in San Antonio.
Yes.
And all of the components of that we achieved toward the end of my tenure in that role. We had primary care docs showing up, secondary care docs like specialists. We even had a hospital system show up and surgery centers.
Nice.
And then we had employers who are the payers for the most part of healthcare.
Right.
And then some knowledgeable brokers and advisors that wanted to really work and advocate for better pricing for
Absolutely.
their employers.
Absolutely,
Yeah.
which is different to what we're used to. So I came in,
Yes.
26 years ago, probably about the same time you did, and I still had a little taste of the private, pay system, which was beautiful. It was affordable. At the time, it was still affordable for people, and I could still, even barter from time to time. It was beautiful. Now, enter in the insurance system within a couple of years of starting practice. And my first check came from an insurance I won't name, but my very, very first check after seeing patients was $1.36.
Oh, my gosh.
And I never cashed it. I kept it and I framed it because it was a symbol to me at the time of where we were headed.
Yeah.
And since then, affordable health care is just non-existent.
Oh, yeah. Well, kind of a 180 from that.
Sure.
Just like a couple of months ago, I had a patient. This wasn't barter, but he's been my patient for years. Mm-hmm. He brought me a dozen eggs from his farm.
Right.
Like, just like, hey, these are right from my farm. Thank you. How awesome is that?
That is awesome. Yeah.
So
I had one lady who wasn't on Medicare yet, 64. I mean, we're off track, but 64 years old, who came in and needed some significant care for potential cancer, And so took care of her, and she offered to cook a meal a week for my family, and we did that. That's how we paid. And that is
those were the good old days.
Those were the good old days,
and so when doctors and patients had that sacred doctor-patient relationship, I don't want to bash the current system, but we have lost that in many ways, yes, and it's so sad. But that's why I'm so excited to find this model of direct primary care that we're going to talk about today.
Yes.
I mean, we always talk in our internal meetings and staff meetings about restoring the doctor-patient relationship. We really believe we're doing that, and it's a beautiful thing. Yeah. And as we talk today on the show, I'm going to share some stories.
Well, I love to hear them, and we're going to jump right in because this is a very, very important. You are very passionate about this. You always have been so passionate. That's what I think I love about you the most. But so explain. This is probably an intense subject or a large subject we could spend a couple of shows on. But kind of explain the direct primary care model, where it started, kind of how it applies now.
Yeah. So the way the model works is, folks pay a small membership fee to the clinic every month. And for our clinic right now, it's $89.
Wow.
And then whenever they need to see a doctor, they can come in, usually same day or next day. It doesn't cost them anything extra.
Wow.
We give them access to us with a HIPAA-compliant, secure app so they can text us. Sometimes we can take care of what they need just by texting. We don't have to bring people in, so we can submit charges to the third party, the insurance company.
Sure.
Video visits are free and included, so we are available to them after hours for those needs. My clinic also gives them 1,100 generic medications for free by mail order, and about 67 urgent care medicines at any local pharmacy. So what I'm describing is just what you get when you have access to a doctor.
Right.
And it's affordable.
Right.
Right.
So, $89 a month. So,
right.
I think with a lot of the health care costs and overhead costs and things, people may find that very mind-boggling. I do, because I still run a solo practice and beat my head against the wall with the overhead and all and the insurances, but. So, how is this different from concierge? Because now people are driven into concierge, but they pay exorbitant, prices.
Well, that's one big differentiator is the high retainer fees, and then the other thing that differentiates us from concierge medicine is that those docs and those practices still submit claims to the insurance company, and we don't do that.
Oh, wow. Okay, so it's kind of an all-inclusive system, and for the employer and all, or
for us with employers, it's employers, depending on their size, they have to have a good, knowledgeable broker or advisor that knows how to structure the benefit plan with direct primary care at the core, and that's really key.
Right.
Because, as you know, and many of our listeners, I'm sure, primary care is so important. And if you have access to primary care, you don't have to go to the urgent care, emergency room. You get screened for chronic conditions early. So you prevent hospitalizations. You prevent finding things at late stage, which drives up the cost of care and causes more illness and morbidity. So access to primary care is so important. And in our model, with the brokers that want to provide this for their employer clients, they have to know how to put us at the core and then customize the rest of it around that, because obviously cancer happens, major surgery happens, accidents happen. So those things need to be layered in. But the ones that can put direct primary care at the core and create a plan design that incentivizes the employees to first go to us, the primary care doctor, those are the ones that can save tons of money with this.
Right.
I have an employer page on our website that illustrates some of the great savings that employers have had with us by doing that.
That's incredible. So if you're an employer, this is, or if you have a business, this is something to look into, because it's very difficult now with the premiums that people pay. It's very difficult, especially for a small business like mine. I have 5 people, and it's very difficult to even afford insurance for myself and my family.
We're onboarding an employer next month that had a 25% increase in their premium from the previous year.
That is absolutely real.
Yeah.
Very valid, very real. So interesting. So, and is it, I guess, how is it different than maybe from Medicare or something like Medicare Advantage plans or whatnot? Because it feels like there's some similarities, but I know it's completely different. So how is it? Because, when we first started getting into the MSOs and everything, when insurance models, kind of first started, it was meant to drive to primary care as a gatekeeper. You're family practice, I'm family practice, and so we do believe very much in the preventative medicine, and I think that was the mindset at the time, but it got into more of a profitability, issue. I'll be nice, but and so that is how I visualize a model like this, is that you kind of combine all the resources together and then you pay kind of a payment into it. But how does that work then? How is it different?
Well, I don't let's see, compared to there's different kinds of Medicare, obviously.
Right. It's more the advantage, I guess, that patients Medicare Advantage, you have a you collectively get all the Medicare patients and their Medicare money and put it all together, and patients have a copay and sometimes a small premium or a small copay to pay, but that the money goes to the people who need it, and those who don't, don't take in some of the resources. So when you mentioned there's some catastrophic, times, and also there are catastrophic issues with patients, but also primary care. So how does that differ?
I think we're not trying to limit people's use of those other services.
Thank you.
But we do a lot. We try to practice the whole scope of our training, in the clinic, to at that fixed cost, that comes from the individuals or the employer. So that might be...
That was the answer I was looking for. Because and that's why I want people to kind of understand the difference. Because, yes, we all have to work under a budget. It's important to work under a budget. I think that's the reason why we're in such trouble anyway, is because we've just kind of unlimited budgets and unlimited money, and that's not really feasible. But I think that, patients deserve to not be, what I have seen through Medicare Advantage and most have, is that they are limited on what the care that they can receive. So that was the answer. So they're not limited, to try to boost the...
We've probably seen examples of folks not getting the care. It wasn't approved, and sort of the opposite of that is that in our model, since the third party is over here for the big stuff like it should be, the doctor is free to practice the way they want. I know you do a lot of things that aren't reimbursed by insurance, but there are so many things out there that doctors love to learn about and get into and share with their patients, and they get wonderful results. But those things are just, so many of them are just not reimbursed by insurance, So that's another contrast as to what you just mentioned as to how it's different.
Thank you.
And we love, as doctors, learning things that are going to help our patients, that are going to heal our patients.
Absolutely.
Right? Yeah.
That was the other answer I was looking for, too. And sorry, I don't mean to throw all this at you like that, but I definitely wanted to describe it, because the other thing I find in working in some of the insurance models, Medicare, Medicaid, actually they're pretty reasonable for the most part, but most insurance models, I am very, very limited on what I can do and how I can practice. And you're right. I do spend a lot of time doing many, many things outside of that and don't get reimbursed. I'm fine with that. It's the right thing to do. But ultimately, it doesn't pay the bills. It makes it very, very difficult. But also, there's resistance. I'll give an example. So I was on one of the Medicare Advantage programs and eventually was kicked off. And the reason I was kicked off was because I spent too much money on my patients. Well, I wasn't giving them bonbons or anything, or sending them on trips, or what am I doing? I'm taking care of my patient. If they need a CT scan, by golly, I got them a CT scan, right? And so, but at times patients are limited and can't get their resources. So that's what I want to hear, that they have access. They can get what they need and not be restricted by a third party.
Yes.
We're not trying to bash anybody here. Please do not misunderstand, but it's very important.
We're just giving people options.
Right.
And I want to thank you so much for letting me come on this show and your platform to let people know that they have options.
Right.
Yeah.
Well, here's another idea, too. So I don't know if this is offered in other cities, other states, or where this lands, but if anybody, this is a national show, so if anybody, out there professionally or as a patient or somebody wants to take on some sort of a model, like this, well, this is a great model to mirror and do, or maybe you guys at some point.
Absolutely. Direct primary care is definitely a movement now across the country.
Yes.
And because we work with employers, sometimes they'll ask us, how many clinics do you have? Or I have people in other cities, other states. We have such a network now, we can handle that. For example, I have some employer clients that have employees in the Rio Grande Valley, here and there, even out in the Atlanta area. So they're like, well, what are we going to do about those people?
Right.
Okay, so I reached out to my colleagues in those places, and I made them an affiliate. And so now they have the same benefit that everybody here does.
That's great.
Yeah.
There you go.
And another thing, sometimes people ask, well, how many locations do you have? Well, we have 2 here in San Antonio and an on-site clinic, but I try to explain to people, it's not so much how many locations do you have, but it's about the relationship with the doctor.
Thank you.
Okay?
Right.
So when you have a relationship with a doctor, you don't need all these locations.
Right. Right.
And when we start talking about stories, you'll start to understand that.
Absolutely.
And see that.
I'm ready to hear a few of those, but may I ask first what about a physician like me? I still do, I feel like a dinosaur in San Antonio that I own my own, clinic. Solo practice, is this something that I could look into as a physician in my practice? Mm-hmm. So there you go. I think it's a great idea, honestly. Yeah. So, well, tell me a few of those, so the other physicians can too, and that's the point as well. Mm-hmm. So give us a few of the stories, your success stories.
Yeah, great. We had a lady, we take after-hours call, we rotate that between the other doctors in the practice, and so it was like a Friday night, and I was the doc that was taking calls, and Friday evening, a lady messaged in our app, and she said, hey, I was in the clinic this morning with my baby, my 1-year-old baby, and now I think she's having breathing problems. Do I need to go to the emergency room?
Right.
So you're a doctor.
Right.
What goes through your head? 1-year-old, and should I go to the emergency room?
Right.
Wow. You got to be very careful.
Yes.
So internally, the pressure's on with me. I don't want to send this lady to the emergency room. She was just in the clinic and saw one of our other docs, Dr. Packard, that morning, and everything was fine. But what if the baby is crashing? Babies can go downhill fast.
Very quickly.
So I'm feeling pressure internally. So I reached out to her right away and started talking to her. And as I was talking to her, she said, I did a video of my baby's breathing. I'm like, great.
Beautiful, thank you.
Upload that to our secure app.
Yes.
So I saw that, and the baby, bare-chested, was smiling, no retractions, just breathing good.
So you felt more comfortable that to reassure her.
Exactly.
Right.
And then, so I said, I think we're going to be okay. You don't need to go to the emergency room. So if I would have let her go to the emergency room like maybe a doc would do in the traditional system, she would have gone there. They would have said, "Oh, your baby's fine."
Right.
And here's $1,000 or whatever
Well,
bill.
you pay the ER doctor, you pay the ER in the hospital, and and all. And so that internal pressure that you're describing is so important, because as a physician, if you cannot, as you mentioned without the video and everything, if you cannot see what is going on, it's hard for patients to convey in terms that you need to know for urgency. The first thing you think is, I just don't want anything to happen to this person, so go to the ER. There's not a lot you can do in that situation except advise that. But in this fashion, you're not pressured by, feeling like your hard-earned work, is not going to be reimbursed, or you're not feeling that liability, issue on top of it. You're communicating with the patient who needs you at that moment, and you're doing it well and safely. There's nothing better.
And the other thing that you're alluding to is that when you have a relationship with your patient, you can not take a chance, but you have a little bit more of a reassurance that there's not going to be a bad outcome.
Right. Which none of us want.
That's right.
No,
but when you don't have that bond or that doctor-patient relationship, other than just an 8-minute visit every couple times a year,
absolutely,
you're not gonna take a chance. You're just gonna say go,
right? Yeah,
So,
and there's a lot of reasons for that, and it's not just because it's Friday night and you don't want to be bothered by it. It's not that. At least not my situation, yours. But, it's not that. There's just so many things that are involved. Now, enter COVID, and that changed our model into more telemedicine, which I know you actually have advocated for a very, very long time. But enter telemedicine, enter videos, enter texting, enter internet, and all. And that was a great positive thing, I feel, that came out of all that. And so, uploading a video of the child safely, securely, as you said, and all, amazing. So that's great. That's something that not all clinics can afford, really, to do.
Well,
the softwares.
They're not reimbursed for
reimbursed. And that time is important. I mean, our time is important, and there's no doubt. Well, I feel like I have a big question to ask you, but we're going to take a short break. And what I want to know, though, before we do, is tell people where they can find this information. This will be on the website, but tell people where they can find more information on this.
So the website is directmedclinic.com. There's lots of information there.
Right.
We have pricing there, like even for our labs. So it's
transparent, as you said. Transparent,
exactly.
Which is beautiful. So all this information will be on my website at drpbetterlife.com. And I'll post that up, and that way people can get in touch with you, even physicians or employers. And is that a good way for people?
Sure. We have a page for employers. We have a page of testimonials and good stuff.
Love it. Okay. Well, we will take a short break. Be right back.
Depression, anxiety, low energy, weakness, these are just some symptoms of low B12 levels. And the absorbable B12 folate supplement that's helping people declare victory over depression symptoms is De Novo Plus B12 by Magna Pharmaceuticals. Patients with symptoms of depression often exhibit low levels of folate and vitamin B12. The human body needs sufficient folate intake to produce the essential neurotransmitters serotonin, dopamine, and norepinephrine. These neurotransmitters alleviate feelings of sadness, anxiety, and gloom. What makes De Novo Plus B12 so successful? De Novo Plus B12 contains readily absorbable folate and B12. That means it's more successful at correcting the root cause of your deficiency, not just the symptoms. Whether you are suffering with low energy, depression, fatigue, or anxiety, you owe it to yourself to learn more at magnaweb.com. That's magnaweb.com. Please let us know at checkout that you heard about De Novo Plus B12 on The Better Life with Dr. Pinkston.
Hi, everybody. Welcome back. I'm Dr. Marianne Pinkston. I'm here. Well, I'm going to be Dr. Marianne. He's going to be Dr. Roger, and we are here to discuss the direct primary care model that and Direct Med. You said is the name of the
Direct Med Clinic.
Direct Med Clinic. Thank you. All right, I apologize for that, but. One of the things that I wanted to talk about, because I know this is going to be on people's minds, is then the hospital. So we talk about a great relationship between doctor and patient. We can access you, after hours, access your team after hours, and which is great, which reduces hospitalizations. And as long as you're in the primary care system, that reduces hospitalizations. But what if somebody needs to go to the hospital? Mm-hmm. Do you lose kind of that direct touch, with your doctor, which has been which most hospitals and insurances prefer anyway, but how does that work in your system?
Yeah, so like you said, when you have access to your primary care doc, you don't have as many hospitalizations.
Right.
Sometimes it happens, though. When that happens in our clinic, we're usually able to just do a direct admission. So if you're not familiar with that term, what that means is that I've seen you in the office and I've done whatever I can, but you're not getting better.
Right.
And you need something that we can't provide in the clinic. So we will pick up the phone and call one of our hospitalist buddies and say, hey, I've got this patient, this, and this. And they're like, oh, okay. Let me get a bed for you.
Right.
And so we send the patient not to the emergency room.
To the emergency
we send
room.
them to the admission desk.
Yes.
We did that a couple of years ago for a patient, and while he was being taken up to his room in a wheelchair, they were asking him, hey, who do you know? Because nobody gets treated like this.
Right. And this is first-class service. Now, what I would love for people to understand is that is always available. That's available, really. And I guess I'll say that it's available to all physicians, but maybe I'm not being fair because, there are some clinics and circumstances where, people are hired and they have to follow certain guidelines and rules. Maybe it's a cost-saving guideline or rule or whatever, and they're not allowed to do that. But physicians are allowed, and your physician is allowed to call and do a direct admit to a hospitalist and group and then go into the hospital that way. I do that. I've done that for a very long time. I have a fantastic hospitalist friend that I know very well, and so we do that. And it's not because we're friends. That's what they do. Yes. And all doctors really can access that. So so that's good that you guys practice that. But I want people to know they can ask for a direct admit most of the time.
And then sometimes our patients will be messaging us while they're in the hospital, like, hey, they're doing this for me, or I got this test coming up.
There you go. There you go. Oh, I wish for those days so much. I used to do my own hospital work, and I'm not sure anybody does anymore. It's something that we're honestly not really allowed to do anymore. But I would love to know, because many of my patients will come back and tell me stories of things that happen. Not bashing hospitals again. We know it's not what we're here for. But there are things that get lost in the cracks, and that is what you are trying to prevent, is the lost in the cracks situation.
We're just trying to take care of our patients.
Absolutely. Well, give us another story then, because I know you've got so many things that are great examples.
Okay. Here's one maybe for employers. I had a safety officer text me one evening. He said, hey, I think I'm going to have a patient for you in the morning. And I said, okay. So the next morning came, and the patient called. He said he was lifting some pipes down out in the oil field down, I think, around Pearsall somewhere, and he felt a pop in his biceps. So I said, okay, stand by. So I probably knew what he had. I called the imaging center and arranged for him to have an MRI. I said, okay, go from Pearsall over here, get an MRI. So he went straight there. He got the MRI, and while he was there, I told him, hey, don't leave until I get the results back. He said, okay. So around lunchtime, I get the results back, and said torn biceps tendon.
There you go.
Right? And so I called my ortho friend, and I said, hey, this is what I got. Do you want to see him now or tomorrow? He said, okay, I'll see him tomorrow. So I told the guy, okay, now you can go back to Pearsall. Here's your ortho appointment tomorrow morning.
Yeah.
Okay, so do you see how many steps we missed?
Listen, that's the old days. That's the way. And my husband, great urologist, you may remember him, Dr. Ed Mueller. That's the way we used to do it. And he complains all the time. Part of the reason why he retired was because he just, many reasons, but one of the reasons is we used to just pick up the phone and call our cohorts and say, this guy really needs to be seen. Send him on over, know. And it was a very tight, wonderful, group like that. Now,
here's another story like that.
I never talk to my docs anymore.
I had another patient. Her and her husband were driving up 281 to a weekend retreat. So it's a Friday afternoon, and she calls me, and she said that as they were driving up there, she was driving, her husband was in the passenger seat on a conference call, and he was falling asleep in and out on the way up there on the call. And that's strange.
Yeah.
So she says, "Hey, are you okay?" He said, "Well, I don't know. I've been having this chest pain off and on." Oh. Well, she diverted right away to the emergency room, and they ended up in Burnett. And so she said, "I'm in the emergency room now. Do you want to talk to the ER doctor?" And I said, "Yes, let me talk to him." So we spoke, and he ruled out for MI, heart attack.
Great.
And I said, "This is probably what he needs." I'm talking to the ER doc. He says, "Yeah, that's probably right." So we figured he needed a Holter monitor. So I talked to the lady again, and she said, "We're going to cancel our weekend retreat. We're going to come right to the clinic to see you." I said, "Well, you can do that, but before you do, let me make a phone call." So I called up the cardiologist, and I told him what happened. And I said, "He probably needs a Holter monitor." And he's like, "Yeah, what's his name? I'll have the staff wait for him." So they went right from there to the cardiologist office on a Friday afternoon and got taken care of. Can you see all of the steps and all the hassle and time we saved?
I can. I can. And knowing that is the way it used to be. That's the way we used to enjoy it. It was perfect and wonderful. And now it is just a headbutt system.
Yeah.
It's so difficult.
Yeah.
It's difficult. And people need to understand it's not just difficult for patients. It's difficult for providers too. We really don't enjoy the new way and new nature of it. And I feel sorry for many of the medical students who are getting out of residency actually and coming into practice. They're never going to know what we've known, and it'd be great to be able to teach them.
Yes, we're trying.
That's great. So, in that, is there anything that I've left out? As far as what patients need to know, and or even employers or anybody that about the system and accessibility and everything. Is there anything you would add?
Well, it's kind of hard for people to understand because people have been conditioned with insurance so much.
Sure.
And sometimes it's kind of like you have to experience it to understand it. We still find that.
Right.
But maybe to help people understand, insurance was designed to pay for the big stuff that might happen to people that would break the bank.
Right. Right.
And so we all have insurance for our cars, but we don't use it to change the oil or change the tires,
Thank you. Yes.
We use it for the big stuff.
Right.
And so it makes sense for primary care to have direct access to a doctor like this.
Right.
Because as we talked about earlier, this is affordable.
Right.
It's insurance that is very expensive. So when you're thinking primary care, you don't really need insurance for that. You need insurance for the big stuff.
Right.
Primary care is accessible, and there's so many people out there that think that they can't see a doctor because they don't have insurance.
Absolutely.
Absolutely.
Isn't it heartbreaking?
It does. It makes my heart hurt,
I will lose a patient for a while. See somebody and get to know them and, establish a great relationship, and all of a sudden it's been like a year where'd they go? And then they'll come back and say, well, I lost my insurance for a year. So they've been off their diabetes medicines or off just their care. If they're not on medication, they're just off their care. We just have to basically start over.
It's so sad from our perspective, because we know that when people go off their meds like that,
right,
they're getting irreversible damage to certain organ systems, and it is so not necessary.
It really isn't. No.
A couple of years ago, I testified at the Capitol in Austin to a special committee on health care that we don't need insurance for primary care.
Right.
And I told them we don't, because I'm proving that we don't. I'm providing affordable care to all of these people without insurance.
Absolutely. That's amazing. That's really amazing. I'm so happy to hear all of this. And so, well, we and maybe forgive me if I missed something in our discussion, but for those whose employer doesn't participate, or maybe they have insurance and they really are having difficulty affording it, or how do they access your system?
Yeah, they can come to our website and reach out to us through there, or they can call the office. It's 210-886-8031 is our phone number.
Yes.
We're happy to explain it more or answer questions about it. If people still have questions after this.
Good.
Yeah.
I just want to make sure people know they can access it. They can reach out. And so, again, I'm going to have all this information, your information, on the website, drpbetterlife.com, and make sure that people know this is a really, really great system. You've done wonderful work. You should be greatly applauded. And I hope that your thoughts and passions and everything continue to change the scope of medicine on a national basis.
Thank you.
I love it.
Thank you. Thank you for what you've done.
Thank you.
You've got a unique healthcare journey too.
Significant, and I'm proud of it, and I love it. So I'm like you. I feel very passionate about my people. So I call them my children. I don't mean that as an insult. They're all my adults, my children, everybody. I've delivered. Maybe you have too, as a family practitioner. But there are people who came from medical school and followed me to residency, and then followed me, as they could, and followed me to practice. I delivered babies for a very long time, and those babies are having babies. I didn't deliver them, but I'm taking care of them, and grandma and everybody else. It is a great old-fashioned way of doing it, and it should be new fashion.
Yes,
it really should.
We're getting there, but it's starting from the ground up.
It is.
It's not going to happen from the top down.
No. Well, it's unfortunate because there's money involved. It's profitability is involved, and that's important. We're all businesses. You have to make a profit. I have to make a profit, but we need to do it in a more humane way. It's such an honor to have you on. Thank you so much, and I will make sure everybody can reach out and reach you. And so information will be on drpbetterlife.com, and I hope everybody has a fantastic week. Thank you again very much.
Thank you so much.
Have a great week.
You've been enjoying The Better Life with Dr. Mary Ann Pinkston. For more information, go to drpthebetterlife.com. That's drpthebetterlife.com. And listen next week for The Better Life with Dr. Pinkston.